Hi, everyone. I just want to do a brief little talk. I promise it's brief. I'm usually lying when I say that, but this really will be about lung cancers or respiratory cancers. So, lung cancers used to be relatively uncommon. But due to the prevalence of smoking, we see that they are a very common cancer type. So when we think about the common cancers in males and females, we've already, at least for the past, I don't know, since I've been at school and stuff, maybe about, I don't want to say how long, but anyways, we considered the most commonly affecting types of cancer in men to be prostate cancer. In females, breast is number one. And then after that, lung in both. And then we have GI. That was always, and I'm talking about pathology. Don't forget, we're in a pathophysiology talk right now. So pathophysiologically, we see these cancers prevalent in tissues. The lung and actually the liver are the two most common secondary sites for cancers. And when I say secondary site, I'm talking about cells that break off from the primary tumor and then lodge themselves in a secondary location if it's hospitable to their growth. Because of the circulatory system, the pulmonary arterial system, it's leading to the lungs. And remember, the lungs have the largest capillary bed in the entire body. Not only is it the largest capillary bed, it's also the most compliant and the least resistant, meaning blood flows through it really easily. So if a tumor cell ends up in the lungs, then it's really likely to grow there. And we would call that a metastatic growth. Meta is change, and stasis means location. So a metastatic growth would mean a secondary tumor that has broken off from the primary tumor and has now started to grow in another area. So it's not other cancer types popping up around the body. It's a piece of the original tumor that, kind of like a seed that pops up from a flower, if it lands in the right dirt with the right amount of sunlight and water, it'll start to grow into another flower. That's the way tumor cells work. Just for your own knowledge, lung cancer has now moving, is that a word? Pretty sure it isn't. It's now moved to be the cause of more deaths in females than breast carcinoma. All right, and when I say carcinoma and talk about cancer types are classified by which germ cell layer they derive from. So we have carcinomas that we'll talk about, and those are generally associated with epithelial types of tissues, so the lining of lumen, so things like squamous cells. But just a note about lung cancer. So here we're looking at a lung, and we see these characteristic sites of emphysema, and we can tell that it's emphysema because we have dilated spaces, which you see in emphysema. The alveoli collapse when we get these dilated spaces. Here we see lung cancer, and the deal with the neoplasia is that it doesn't look like the parent tissue. It's not an adaptive change where we see hyperplasia. It is not just more lung cells. It is an abnormal type of tissue cell that has started growing in that area. And I also want you to notice, see how there's some white there? In order for a tumor to grow, it needs to accumulate fibrin, kind of like a skeleton. It allows it to take on more mass. So it doesn't resemble the parent tissue. That's the whole point of neoplasia. It's a new tissue. And in order for it to grow, it needs its own vascular supply. So you will see if you cut this tumor open when it's live, it would be bloody and relatively red. And it also needs its own fibrous, cartilaginous material in order to grow. So lung cancers, 87% of them are considered smoking-related cancers. And as I drew out for you on the prior slide, it's common in both men and women, with it now eclipsing deaths due to breast cancer in women. One of the most common places for it to arise from, because of the anatomical location, so if we've got the trachea and then the bronchi and then the bronchioles, branching off of those within inside of the lungs, when people are doing things like smoking, the areas that are in contact with that irritant are the linings of things, right? The epithelial tissue. So remember, from a cellular perspective, when there's constant irritation to an area, the cells will undergo adaptive change. First, they'll undergo hyperplasia, so they'll make more copies of themselves, and then we'll see metaplasia, so the tissue type will convert to a new one. That'll progress into dysplasia, which we call precancer, and that is characterized when there's the presence of multiple, what we call pleomorphic cells, so cells with abnormally shaped and then visibly altered cytoplasm to nucleus ratio. And I say visibly because they stain very darkly when you're looking at them histologically. And when a tissue takes on all pleomorphic cells, we consider it neoplasia, and that's when we call it malignant or cancerous. So because of the fact that it primarily is bronchiogenic, meaning it's created in the bronchial tissues, it is sometimes referred to as bronchiogenic carcinoma. And when we're thinking about how we treat lung cancer, it can be treated in a variety of ways. Chemotherapy is a non-specific type of drug therapy that targets quickly dividing cells, because cancerous cells divide and replicate very quickly. However, there are other cells that replicate and divide very quickly, like hair cells, like cells of the GI epithelium, like marrow cells. So it's not selective in that you give a chemotherapeutic agent and it magically just kills the cancerous cells. It kills any cell that's rapidly dividing. Typically, it's targeting a cell in a specific phase of the cell cycle, like maybe the M phase, which stands for mitosis. But you might know that the three most common side effects of chemotherapy are alopecia, or hair loss, GI disturbances, and lethargy. And that is because of it targeting those cells in the GI epithelium, causing gastric distress, red blood cells not being made adequately, so you get lethargy through anemic symptoms, and hair cells, the hair starts to fall out because those cells are targeted. Radiation is a little bit more targeted because you can use beam radiation to just essentially pump radiation, which is cancer causing itself. So we are harnessing the power of this really potent agent to cause DNA strand breakage. And without its DNA, a cell can't replicate. So radiation can be used to arrest tumor growth and a lot of the time give immediate relief for symptoms. There's also resection. You can do a removal of just the tumor. You can do a removal of a lobe of the lung, a lobectomy. You can remove an entire lung, a pneumonectomy. Not every cancer type is really responsive to chemotherapy. One of the worst types histologically and also prognosis-wise is called small cell carcinoma. And when you look at this pathologically by a histological section, they almost resemble leukocytes. But even though it has really poor prognosis, it does respond to chemotherapy, at least in the immediate, providing some relief of symptoms. However, one of the reasons it is a very poor prognosis is small cell lung cancer is a reoccurring cancer. So you'll see the small cell carcinoma, and you'll see why it's called that on the next slide. They're small cells. They look like leukocytes. They're irregular. They've got little scanty, tiny little cytoplasm, but it's a reoccurring cancer, meaning you get a tumor that pops up with small cells in it. You can hit it really hard with chemo and radiation, and the cancer goes away in the meantime. The patient finds some relief. They might ring the bell at their cancer hospital, but essentially what you've done is deplete the immune system of that patient. So when it inevitably comes back, it is always fatal. If you want to learn some positive news about this, there is something referred to as the cancer vaccine that's not really a vaccine. It's using a more interesting autoimmune approach, but what it does is selectively lengthen the lifespan of patients who are suffering from the reoccurrence of small cell carcinoma, and where you see the symptoms of its reoccurrence be, eventually death and very, very negative side effects associated with the chemotherapy to treat it a second time. The number one reported side effect of the vaccine is irritation and itching at the site of injection. And it's been shown to lengthen survival from the typical 6 months out to about 2 years, which is a lot of time. So that's a newer therapy. Also, there used to just be two classifications for lung cancers. There were small cell and then large cell, and that used to be enough. By figuring out which one would respond to chemotherapy. But now we will add two more histologically. We have squamous cell carcinoma, which squamous cells, remember, they're epithelial cells. They line things like the lumen of bronchioles and bronchi. And because a lot of these are smoking-related changes and the inside of the tubes are where the irritants come into contact and change the cell expression, we see these be very common. Adeno means gland or organ. So an adenocarcinoma is another common type of cancer, which first of all is more in the periphery of the organ. So with squamous cell, you would see that inside of something like a bronchi or bronchiole, causing a mechanical obstruction. Adeno is in the periphery of the organ, and the adeno in there is also describing the glandular-like appearance of the cells that you will see. So just to give you an idea of this, again, remember that when we're talking about neoplastic tissue, we are talking about tissue that is new. It does not resemble the parent tissue. So this is a squamous cell carcinoma. Remember, squamous cells in the lining, and this has then caused an abnormality through this typical cellular injury progression from hyperplasia to metaplasia, dysplasia, now neoplasia, and we have a tumor growing with inside of the bronchus. So this would be a primary tumor of the lungs, meaning this is where the cancer started, and it's bronchiogenic in that it started from the bronchial tissue. So this down here is an adenocarcinoma. So adeno is organ or gland. So an adenocarcinoma is referring to the organ itself. That's not generally inside of a bronchi or bronchiole because it's not made out of squamous cells. It's made out of parenchymal cells. So we call it an adenocarcinoma. So this is arising from the lung periphery. And just to go back to the histological presentation, this is what a squamous cell carcinoma would look like. When stained histologically, we see the darkly stained nuclei. We can see the fibrous extensions here, which let you know that that is the tumor growing larger. And this would be the histology of a small cell lung cancer with very scant cytoplasm. So it's almost like all nucleus in these cells, which would be similar to what you would see in leukocytes, but these are not leukocytes. These are neoplastic cells, and that is the poorest prognosis out of all the lung cancers, but it's also one of the targets for the newer technology of the cancer vaccine. And that's all we have to say about lung cancers right now. Thank you. Stay smart.